you for the introduction, Professor Pu, and I really appreciated this opportunity to share with our experience and data with our European colleagues about the shock team. So we all know that the incidence of cardiogenic shock has been increasing during the last decade, and the in-hospital mortality remains high. So what we learned from the American research data, you can see a drop between about 2008, but when it rises up again, and unfortunately, we don't have too much data of the cardiogenic shock in China. So this chart just shows the China shock registry in the emergency room, and you can see that the 3-day mortality of cardiogenic shock is very high. It's only 3-day mortality. So we have big challenge for the management of cardiac shock. Unfortunately, at the same time, we short of high-level evidence. I mean, the randomized controlled trials to show any, to reduce the hard endpoint. It refers to the mortality and even hospitalization. So we only have the impeller track, the danger shock trial to show that the mechanical circulation support can reduce the mortality at 6 months. And we do not have any superior medications when we treat patients with cardiogenic shock. And what we learned from our American colleagues is that there are a lot of so-called shock team or shock program maybe can improve the prognosis of patients with cardiogenic shock. All this kind of algorithm just combine the collaborator between the low-level hospital and high-level hospitals, and it will include all these techniques, including pulmonary artery catheter and medications and very individualized selection of the mechanical circulation support. So, so we have learned a lot from our European Heart Journal Acute Cardiac Care in the 2024, and there's a paper in 2023 to show that this multidiscipline cardiogenic shock team can really improve the patients with resistant or refractory cardiac shock patients. And you can look at this is a double cohort study to show that the patients, if combine the patients in the historical cohort from 2007 to 2013, and with the patients included between 2013 and 2019, you can see that the cardiogenic shock team can really improve the 1-year survival. And what we are doing now in Anjing Hospital, this is our shock team model. All the patients admitted in the appeared at the emergency room will be assessed by a ERCS bundle, and including ECG, the lactate, the troponin, BNP, and the ultrasound, and CT angiography, and to early identification, those patients in early shock, and to classification. I mean, this is the classification that recognize specific etiology, such as PE, pulmonary embolism, or aortic dissection. And then the cardiac critical care cardiology will call all these team members, including ECMO team, intervention cardiology, and cardiac surgeon, to come to the emergency room and to evaluate the indication for the mechanical circulation support, and then to divide the patients with 2 major type of CS, the AMS CS, and acute decompensated heart failure CS, and to talk about the selection of this MCS as well. So this is the first step. It will almost follow the same this process in our emergency department, and so the first line medication, almost in all these guidelines, vasopressor and inotropics was recommended as the first line medication for patients with cardiogenic shock. But for some subtype of the cardiogenic patients, such as patients with decompensated acute heart failure, so in our center, so we have experience to use the nitroprusside combined, with the natural inotropics and vasopressors together to reduce the mortality and maybe the rehospitalization. So we are designing this trial, and we are going to doing this trial to look at if the early use of these vasodilators could improve the prognosis. But obviously, all this medication dosage and should be guided by the hemodynamic parameters. And what we have learned from the all these randomized trials for the AMI-CS is that all these MCS devices do not reduce the 6 months mortality, and even the use of the MCS should be restricted to a certain type of patients. I think our previous speaker has talked a lot about the VA ECMO and the Impala result. And we can say from that, the subgroup analysis, we can see from this meta, the 6 months all-cause mortality for patients STEMI without the risk of hypoxia brain injury maybe can benefit from this MCS compared to the control group. And this is data just published last year. So this data is comes from the Chinese Registry of ECMO. Thus, we have Association of Chinese ECMO. So this is the data included about 5,000 patients with CS treated with VA ECMO from 2017 to 2023. What we have found in this registry is that even after the propensity score matching analysis, we can see that the IBP unloading can maybe improve the prognosis of patients receiving VA ECMO in this trial. And our head of the ECMO department, Professor Hou Xiaotong, is doing a prospective randomized clinical trial to see if early use of IBP after VA ECMO can really reduce the mortality for patients. So so one of the major issues in the maybe influence the results of these trials and maybe influence our clinical practice is how to prevent the complications. So this is our standard anti-quality monitoring algorithm. So what we have learned from our patients that the incidence of bleeding and thrombosis is very high before our shock team project. So we talked with our specialties in the internal department, and we just established this scan, to monitor all the patients who are receiving the mechanical circulatory. So this is a very unpublished data, just a very drafted data to show the mortality, in-hospital mortality, admitted in our critical care unit. And you can say the in-hospital mortality reduced from 50% to 39% during the last 2 years after we initiated our shock team. And another influential part of the shock team is our cardiac surgeon. So Angel Hospital has the most the largest number of cardiac surgeons in China. So this is a post hoc data analysis of patients with post-AMI ventricular septal rupture during the last 3 years. So we can see that we just do the analysis to show the timing of the surgery. So we can see that for patients who can survived after 40 days, so the mortality is lower for those compared to those patients just received the surgery within 3 days. So another issue in China is that we have a variety of economy development in our world country, and so there's a lot of information to show that the hospital volume is associated with the mortality of patients with CS and MCS. So this is a registry from the 3C study. 3C study is the HA-initiated study in China to improve the care of cardiovascular disease in patients with acute coronary syndrome. So we selected 2,700 patients with AMI, CS, and to show that the adherence of the guideline recommended treatment is very low in patients with suffered cardiogenic shock compared to those without. So there's another model from our Chinese colleagues that is from the Huazhongfuai Hospital. So Huazhongfuai Hospital just located in the Henan province. So there are about 100 million residents in Henan province, and they established a so-called transfer ECMO pathway to rescue all patients with cardiogenic shock. And the challenge of management and the challenge of the health provider in Henan province is that there's a very big variety of the equipment allocation and the technical capacity between these different areas. So this shows that there's a very rare, the proportion of the hospital has ECMO or impeller is very low in Henan province. And this is show the technical capacity in Henan province. We can see that ECMO is very low, and even CRRT is very low. And so our society want to follow the international criteria, to accrediting different level of ICUs. And the main aim is to improve the ability and the capacity of all these intensive care unit to for the management of cardiogenic shock. So this is my last slide, and when we talking about the rescue and management of patients with cardiogenic shock, so we need multidisciplinary teamwork and to give the right patients the right treatment at the right time. So thank you very much for your attention. Yeah.